All right, so started the recording. We'll go ahead and get started. Welcome everybody to this webinar hosted by the Arizona ADRC Data Management and Statistics Core. My name is Mike Malakamati from the Banner Alzheimer's Institute. I'm very, very happy to welcome Dr. Bruce Uten from the Massachusetts General Hospital and Harvard Medical School today. Dr. Uten received her PhD from the Alzheimer's Center of the VU University in Amsterdam, where she specialized in the measurement of cognition and everyday functioning in dementia. As part of her PhD training, she developed and validated a measure of cognition and function, the cognitive functional composite, to address the need for a reliable, valid, and sensitive measure to assess clinical progression in early symptomatic stages of Alzheimer's disease. After obtaining her PhD in 2019, she received a prestigious Dutch NWO Rubicon grant for a 2-year postdoctoral fellowship in the Harvard Aging Brain Study, where she works with Drs. Kate Papp, Doreen Rentz, and Risa Sperling, and where she focused on using computerized cognitive testing to improve the detection of cognitive changes in preclinical AD. In 2022, she received an Alzheimer's Association Research Fellowship grant to continue her postdoctoral research at MGH. Her current research projects focus on leveraging remote mobile cognitive testing to capture the very early yet meaningful changes in cognition that manifest during the preclinical stages of AD. Bruce, very happy to have you today. And just to let everyone know that at the end of the talk, we will take questions either through the chat or you will be allowed to unmute yourself and ask questions live, if you will. Today's webinar is also being recorded, so anybody who would like to view it afterwards or who is not able to attend during the time right now, it will be available on a YouTube page that the link will be sent out to later. So Bruce, I will turn it over to you and let you go ahead and get started.
Thank you. Thanks, Mike, for the introduction and for the invitation to talk about my research today. It's very wonderful to be here. And I'm very happy to talk about the projects that I've been working on these past few years at Mass General that focus on leveraging remote, unsupervised digital testing to capture cognitive change in preclinical Alzheimer's disease. So let me see if I can advance. Yes, here we go. So just to start with the background on preclinical Alzheimer's disease, many of you will be aware that both Alzheimer's research and clinical trials are increasingly focusing on this preclinical stage of Alzheimer's disease. So individuals who are cognitively unimpaired, but have abnormal Alzheimer's disease biomarkers, such as elevated amyloid and tau. And this is because it is thought that this preclinical stage really provides a window of opportunity to intervene with Alzheimer's disease pathology before the onset of mild cognitive impairment or dementia. However, the ability to detect and track these very subtle cognitive changes has been a significant challenge for the field. And especially using classic standardized cognitive assessments, which are usually administered in the clinic at a single time point and then repeated annually. So for example, studies have shown that these traditional tests exhibit only small or tenuous associations with amyloid and tau in this preclinical stage. And decline is only captured over multiple years, and especially just before the onset of MCI. And that is not surprising because these tests were all developed to detect MCI and dementia and not to detect change in this very early preclinical stage. So there is a need for cognitive measures that are sensitive to these very, very early subtle changes. And I think computerized or digital cognitive testing may help us. So first, overall, computers, smartphones, and tablets are becoming ubiquitous and increasingly accepted and used by older adults. So for example, studies have shown that more and more older adults possess either a smartphone or a tablet or computer. And they're also increasingly willing to use their device to monitor health, including their cognitive function. And this really opens the door to the implementation of digital tools that can provide more sensitive measures of cognition than those traditional in-clinic paper pencil measures. So like one overall advantage of computerized testing is that it allows for standardized administration and data analysis, which results in more precise and fine-grained measurements. So fewer scoring errors than a human rater, and the ability to capture both accuracy scores as well as reaction time data simultaneously are two of those examples. But also, I think interestingly, this allows for unsupervised testing, so people could take the test on their own device at home, which decreases the burden of having to come in to the clinic, and therefore allows for much more frequent cognitive assessments, so assessing cognition monthly or daily. And this is particularly the latter, so like being able to capture cognition more frequently enables the study of previously understudied cognitive paradigms. And I will be talking about two of those today. The first is leveraging more frequent assessments to measure learning over repeated exposures, so leveraging the phenomenon of practice effects. And then the second part of my talk, I will be talking a little bit more about within-person inconsistency over repeated exposure or intra-individual variability, and how that could provide additive information about cognition, especially in preclinical disease stages. So to start off with the focus on practice effects. So practice effects are improvements that are seen on repeated cognitive testing in the absence of an intervention. So this is the phenomenon where simply due to familiarity with testing, the test content or the test procedure, people perform better when they are re-exposed again to the same test. So that's something that we very typically see in cognitive, repeated cognitive testing. And practice effects on cognitive testing have typically be viewed as a source of bias. But more recent studies have actually shown that it might be that practice effects might provide a clinical marker in that reduced practice effects may be an early marker of cognitive decline. So, for example, studies have shown looking at repeated cognitive assessment over years that those individuals with preclinical Alzheimer's disease exhibited reduced practice effects in the setting of otherwise normal performance. So like cross-sectionally, they would perform similar as those without AD pathology, but over time, they show reduced practice effects. And in this review that we did a couple of years ago, we've really found continuing supportive evidence that lower practice effects on cognitive testing are associated with future cognitive decline. And further, recent evidence suggests that reduced practice effects in preclinical Alzheimer's disease may actually reflect very early failures in memory consolidation. So that is the process where temporary memory is transformed into a more stable form, a process that requires the passage of time, which you can capture by more frequent assessments and not just within a single time point testing session. So, for example, in this study, we gave 94 cognitively unimpaired older adults an iPad to take home for a year, and they completed monthly testing, and we had them complete 2 versions of a face name memory test each month. In one of the versions, they had to learn and remember the same faces and names every month. So you see their trajectory on the left. And in the other, they saw alternate faces and names every month, and you see the trajectories plotted here on the right. And as you can appreciate, that performance or the amount of practice effects only diverged between those with and without Alzheimer's pathology when the same test was administered with the exact same content. And you can sort of see this reduced learning or reduced practice effect in those with amyloid, elevated amyloids. And this finding that reduced learning curves or practice effects are primarily observed when the same version is presented every every month suggests that individuals with Alzheimer's disease pathology are not benefiting from repeated experience as their counterparts without Alzheimer's disease pathology, and suggesting that these failures in memory consolidation might be a very early sign of Alzheimer's disease-related cognitive change. So we aim to expand on this by investigating whether quantifying practice effects across a range of memory tasks that were included in a remote monthly administered computerized cognitive composite could aid in the detection of early learning or consolidation deficits in preclinical Alzheimer's disease. So we first investigated the nature and magnitude of practice effects on these monthly repeated measures. And people were exposed to that monthly for over 1 year. And second, we examined whether diminished practice effects were associated with Alzheimer's disease biomarker burden as measured with PET, so amyloid and tau PET, and whether they were predictive of cognitive decline on standard paper pencil testing over 1 year. So to that end, we included 114 cognitively unimpaired older adults from the Harvard Aging Brain Study, or HABS. HABS is an ongoing longitudinal observational cohort study of community-dwelling older adults who are cognitively unimpaired at the time of enrollment. And as part of HABS, they also have a yearly in-clinic cognitive testing using standard paper pencil tests. And here we focus on the preclinical Alzheimer's Cognitive Composite 5, or the PEC-5, which is a multi-domain cognitive composite, including the MMSE, logical memory, digit symbol coding test, and free and cued selective reminding test, which are well-validated paper pencil measures that are used in preclinical Alzheimer's disease research and trials. So they underwent that at the time of their first computerized assessment. And they also had an amyloid and tau PET scan available within 3 years of their at-home baseline. So then they did the C3, which I will show you in the next slide, but they did it for 12 months. And then from a subsample of individuals, we had a second time of in-clinic testing available so that we were able to compare monthly performance to change on the annual in-clinic testing. So this is the computerized cognitive composite, or the C3, that they did monthly at home on the iPad that we gave them. And for the practice effect question, we focus on the 3 memory measures where we expect most practice effects to happen over time. So briefly, the first memory measure was the behavioral pattern separation task, or BPSO, which is a measure of pattern separation, and which is an aspect of episodic memory where information from overlapping experience is made independent of another to overcome interference. So here, during the encoding phase, participants are presented with a series of unique images, which is followed by a recognition phase that includes these repeated, the images as they have seen before, novel images, as well as distractor images. So they're like slightly the same, but not exactly the same. And then participants are asked to categorize these into old, similar, or new. And of interest here is the rate at which participants can correctly identify lures as similar rather than as old. And that is captured by the lure discrimination index. The second memory paradigm that we focus is on the phase name associative memory exam, for which participants are shown 12 phase name pairs. And after a 15-minute delay, there are 3 measures of memory, including first letter name recall, phase name matching, and phase name recognition. And we focus on phase name learning here, or FNLT, for which participants are asked to select the first letter of the name that was paired with the phase. And the third memory paradigm is the one-card learning test, which uses playing cards as stimuli to measure immediate memory. And here participants have to learn a series of playing cards by responding yes or no to whether the card has been previously shown in the task or not. So these three memory tests are combined into a C3 primary outcome. It's been a validated metric. And we looked at monthly performance on this like C3 combined outcome. However, what is good to take into account here is that the retest procedures slightly differed for these tests. So for the phase name test, they saw the same version every month, whereas for the BPSO, there were 4 versions that were being alternated over months with the same order for each participant. And then the one-cohort learning used alternate versions each month, which were also randomized per participant. So this is something to keep in mind when we look at the trajectories of practice effects on the individual measures, which I will also show you. So here are the demographics and the clinical characteristics of those 114 individuals, as well as the subsample which by the time that we did this study had a in-clinic follow-up available. Overall, this subsample was not different from the total sample in terms of demographics and clinical characteristics. Just a few things to highlight. Adherence was high with an average of almost 12 C3 assessments. So almost everyone did it monthly. On average, participants were 77 years old, 2/3 is female, and with a mean of years of education of 16. A sample was relatively high educated, but that is reflective of the larger HAPS cohort. All baseline cognition score, so CDR, MMSE, and the PAC score, the preclinical Alzheimer's cognitive composite, fell within a normal range. But amyloid and tau biomarkers were variable, and in fact, a quarter of the sample was classified with amyloid positive, and these individuals also had higher tau uptake in the 2 Alzheimer's disease relevant regions, so the entorhinal cortex and inferior temporal tau. Here you see the monthly trajectory of the C3 score and for the overall group, and you can see immediately that overall individuals improved over months on this composite, but also on all the individual measures, which is also presented here by the slopes from linear mixed models, corrected for age, sex, and education, showing a positive estimate, meaning that there was monthly improvement. So on the overall C3 score, like 0.2 was standard deviation, but on the individual measures, we also saw improvements. But interestingly, the practice effect was strongest for the phase name measure, the first letter recall, which was administered using the same version. So we repeat the finding from previous studies that using a same version really boosts your ability to capture practice effects. But then what I think is also interesting about this graph is that we can see that most improvement happens over the first few exposures, and that then like people reach a certain plateau or and yeah, stay on that like level for the rest of the trajectory. And that is also in line with previous studies that have shown that practice effects typically are most strongest over the initial exposure. So what we did here is we cut the data and we looked at those first 3 months, and we indeed found that the estimates, so now these present the estimates using only the first 4 assessments, first 3 months of data, are much stronger than when they were sort of averaged over the 12 months. So improvement over 3 months is greater, and suggesting that stronger practice effect over initial exposure. And then what we did next is we extracted for each individual, we extracted their slope over these first 3 months, so correcting for age, sex, and education, providing sort of their magnitude of practice effect, right? So everyone improved, but there were differences in the amount that people improved. And we took that slope and we associated that with amyloid burden on PET. So on this graph, you see there the slope for each participant and their C3 slope over the first 3 months. Again, everyone has a positive slope, everyone improves, but some people only improve with 0.3 of a standard deviation and others with 0.8. And we see that the strength is associated with the amount of amyloid in their brain. So those with less improvement had higher, on average, higher amyloid. And we saw the same association with entorhinal and inferior temporal tau in that worse slopes, so reduced practice effects were associated with greater tau deposition. And remember, these slopes were corrected for age, sex, and education, so we're not looking at an age effect here. This really suggests that this the slope, this amount of practice that some person showed is tapping into like something that's associated with underlying Alzheimer's disease biomarker burden. And then in that subsample who had follow-up in-clinic testing available, we looked at whether the slope over the first 3 months of a monthly testing was associated with annual change on that in-clinic standardized cognitive measure, the PAC-5. And here we found as well that those who showed less improvement over 3 months had a greater annual decline on the PAC-5. And in this area on the curve figure, we used the 3-month slopes to see how well that could discriminate those who would show more than 0.10 standard deviation annual decline on the PAC-5. And we found that the slopes did pretty good with an AUC of 0.91. And this was actually that the slope actually had better discriminative ability than just baseline C3 or the baseline PAC. So really showing that this 3 months of data provides you with more information that is relevant for predicting who declines or not. So to summarize this part, so we found that cognitively unimpaired older adults show practice effects on monthly repeated computerized testing, and that as expected, practice effects are stronger over the initial repeated exposure, so the first 3 months, and especially when repeating the exact same version of the test over months. However, although everyone improved, there were people who improved less than others, and we found that diminished practice effects over these first 3 months were associated with greater amyloid and tau burden and also with cognitive decline over 1 year, suggesting that characterizing practice effects on this C3 over 3 months could provide a valuable marker to identify individuals who are at risk for short-term cognitive decline. And these findings provide complementary evidence for the hypothesis that characterizing short-term practice effects could aid in the detection of individuals at risk for cognitive decline due to Alzheimer's disease and above and beyond just a baseline or single time point cognitive test score. And as such, capitalizing on the phenomenon of practice effects could accelerate clinical trial recruitment and screening, and potentially also the detection of treatment effects compared to using or traditional in-clinic standard testing in this population. Moreover, I think what this type of learning paradigm seems particularly sensitive to preclinical Alzheimer's disease, and is also now increasingly feasible to administer using remote digital testing and to potentially detect these practice effects, maybe even over shorter time intervals, such as the course of a week. And this is a hot off the press paper that was published by our group a couple of months ago, actually, where we took the same sort of memory paradigm. So we had 3 memory tests, but they were implemented on, people took them on their own device, their own smartphone or computer, and they did this testing over days rather than months. And here we also see that those who were amyloid positive showed a diminished learning curve over 7 days, really showing that this multi-day learning curve paradigm was able to detect early amyloid-related changes that was not detected by only day 1 performance. So this is, I think, very exciting, and this is something that our group is now continuing to work on, and also looking at the association with tau in this group. But I think this is all like really nicely showing how leveraging the phenomenon of practice effects can really tell us something about early learning failures in unimpaired older adults. And these are the two papers that I made that showed the results of. They are open access, so you should be able to find them if you want more information. Then switching gears a little bit. So the second thing that I was going to talk about is intra-individual variability. So as a bit of a background, while individuals with neurodegenerative disorders typically present with impaired cognitive scores compared to matched healthy controls, there is also evidence that subtle neurodegenerative changes can manifest as within-person inconsistency or abnormally large intra-individual variability in cognitive performance. And this type of intra-individual variability, or IIV, can be operationalized by variation in reaction time performance within the same individual across multiple trials within a single session or across multiple sessions that occur over longer time intervals. So assessing the same tests to the same individuals over multiple times, and then looking at how their reaction time is changed, or like how consistent their reaction time is. And this is an old study that showed this example from McDonald et al., where you see that like healthy controls and how their reaction time is like doesn't fluctuate as much over the course of trials. Whereas a group with dementia, even though overall they might have the same average, their pattern of inconsistency is much more prominent than those of healthy controls. And while intra-individual variability in reaction time increases with age, so older people show more like larger fluctuations than younger people, evidence suggests that increases beyond normal age-related limits are associated with greater risk of cognitive decline in Alzheimer's disease and related dementias. So, for example, studies have revealed that increased trial-to-trial IIV in reaction time in cognitively unimpaired older adults is associated with APOE4 carrier status and also elevated amyloid pathology. However, it's not really yet fully understood what type of brain function is captured by increased IIV, like what kind of cognitive process does it reflect, and whether it is useful for the prediction of cognitive decline in preclinical AD beyond just like standard or average reaction time scores. So to that end, we aim to investigate whether quantifying intra-individual variability over monthly, remotely administered computerized reaction time tasks could provide an indicator of emerging cognitive decline in preclinical AD. So first, we aim to examine the association between IIV in monthly reaction time performance and performance on standardized in-clinic neuropsychological tests covering multiple cognitive domains. And second, we investigated whether increased intra-individual variability in reaction time would be associated with future cognitive decline in those with preclinical AD, and whether this would be above and beyond their mean reaction time performance. So this is using the same sample as we studied for the practice effects. So in between the monthly memory measures, or like during the same assessment, but in between two memory measures, participants did a couple of reaction time tasks just to fill the delayed recall between the two memory tests. And we use that reaction time data here to look at the individual variability. Also, by the time that we undertook this study, like there were more people with in-clinic who came back to the clinic, so we had more longitudinal data available to look at cognitive decline as administered with the paper pencil testing. These are the two reaction time tasks, or the 4 reaction time tasks that we will be focusing on, of which 2 can be classified as simple reaction time tasks. So like a yes or no button that had to be pressed, whereas the 2 other tasks were a little bit more cognitively demanding, so also included a working memory aspect. Briefly, the detection task is a measure of attention for which participants are asked to respond when a stimulus card is turned face up. And the identification task measures attention and inhibitory control, where a respondent has to choose whether a card is read or not. So these are the two more simple reaction time tasks. And then for the one-card learning task, which I've shown you before, participants are shown cards one at a time, and then they are asked to indicate whether they have seen the card before or not. And the one back task is requires participants to match a card to a previous card, and then they have to indicate yes or no whether the current card is equivalent to the previous one. So these first two are more simple reaction time tasks, and the other two are more complex reaction time tasks. And for each task, we computed intra-individual variability estimates by computing the intra-individual standard deviation of each participant's monthly reaction time performance, after regressing out the effects of age and session to remove any systemic sources of variance. And this is a commonly used approach to study IIV. And then for the detection and identification IIV estimates were averaged into a simple IIV composite, and the other two tasks were averaged into a complex IIV composite. To remind you of the sample, the 114 individuals and they're 77 years of age. And I remind you that remember that 1/3 of the individuals was classified as amyloid positive. And here you see their individual trajectories over months for each of the 4 reaction time measures, really showing that there are differences in how much people fluctuate over months. So we then computed the IIV estimates for the simple and complex IIV composite, and we looked at cross-sectional associations between cognitive domains that were assessed using tests in the clinic. And we found that overall, maybe unsurprising, greater IIV was associated with worse performance across cognitive domains. So those with greater IIV, greater variability, also performed worse on other cognitive tests. However, when we controlled for mean reaction time, only intra-individual variability captured by these complex reaction time tasks was associated with worse executive function. So all of the other associations attenuated or did not survive our multiple correction. So really suggesting that it is this type of IIV that is uniquely associated with executive functions. And then we examined the association between simple and complex IIV and longitudinal cognitive change as measured with the in-clinic PAC-5 battery. And we found that after correcting for covariates, greater IIV on the simple reaction time tasks was associated with worse baseline performance, but not with change over time. Whereas greater IIV, again, on that complex reaction time measures was associated with lower baseline PAC performance, but also with accelerated cognitive decline. So those with greater IIV, so larger fluctuations over those first months, also declined faster over years after on the standard in-clinic assessments. And then when we included mean reaction time in this model as an additional covariate, all these effects for complex IIV remained similar in magnitude. So the IIV was really adding to these models above and beyond mean reaction time. And then finally, when stratifying on amyloid status, we found that the association of greater complex IIV and accelerated cognitive decline was really driven by those with high amyloid, so those who we would classify as preclinical AD, and which was also independent of mean reaction time performance. And in this group, the IIV was also associated with inferior temporal tau, so suggesting that this type of IAV was associated with biomarker AD biomarker burden among these normal individuals. So to summarize, we found that increased IIV was associated with overall worse performance on various standardized neuropsychological tests, which is in line with previous work. However, when mean response time was taken into account, only increased IIV on complex reaction time measures was independently associated with worse executive function performance. We also found that increased IIV on these complex reaction time tasks was associated with faster subsequent cognitive decline and above and beyond mean reaction time performance, particularly among those with elevated amyloid. And I think altogether, these findings suggest that increased variability on monthly complex reaction time measures may reflect subtle early executive function deficits and be associated with short-term cognitive decline in preclinical Alzheimer's disease. And these findings provide complementary evidence for the hypothesis that IIV may provide additional insights into the operation of cognitive systems that are different than processes captured by a mean reaction time score or a single time point cognitive score, and that this is already relevant in the preclinical stage of Alzheimer's disease. However, like IAV in itself was not predictive of having amyloid or not, so it might not necessarily provide a specific marker for detecting amyloid-related memory changes, but rather maybe provide a marker of preclinical AD progression. So it's higher in those who are further along the preclinical AD trajectory and when they already start to develop executive symptoms, or perhaps due to co-pathology of other biological factors that may influence their ability to maintain a consistent performance over time. So I think in the future, it would be really interesting to look at some of those potential biological correlates of increased IIV as this early dysexecutive symptoms, such as vascular risk factors, which we haven't looked at all in the context of this group yet. This is the paper that came out last year where we discussed this study. So again, recommend you to take a look if you have more questions about our approach and findings. And I would like to end with a few take-home points and future directions and maybe some points for discussion, like not only based on what I've shown today, but I think based on other really interesting work that is out there using these remote digital cognitive assessments that show that that remote, unsupervised, computerized cognitive testing, which is now increasingly feasible among older adults, offers the opportunity to deploy novel test paradigms that provide unique information about cognition and may aid in the detection of very subtle Alzheimer's disease-related cognitive changes before the onset of detectable impairments such as MCI. Practice effects and IIV are two examples, but I think there are many other emerging promising digital approaches such as ecological momentary assessments, passive sensing, voice biomarkers that all have the potential to transform our field by overcoming limitations of paper-pencil approaches, but also providing novel insights into the nature of cognitive change in preclinical Alzheimer's disease, but I think also in other neurological disorders. However, it's good to realize that many of these studies, including our work, has been done in quite highly educated and tech-savvy cohorts. And for successful implementation, obviously further validation is crucial, especially in more diverse populations, and with a focus on acceptability, feasibility, and reliability in individuals with lower digital literacy. However, I think ultimately by providing more efficient, scalable, accessible assessment of cognition, remote and supervised digital cognitive tools may facilitate the identification and tracking of early change and in individuals at risk for cognitive decline, which is relevant for research, clinical trials, but eventually perhaps also in real-world settings such as primary care practices. And with that, I'd like to thank and acknowledge, first of all the Harvard Aging Brain study participants and the study team, my mentors over the course of my PhD and now during my postdoc, the funding, and finally you for bearing with me on a Friday afternoon, morning, or maybe even evening. And I'm happy to discuss findings and answer any questions.
Thank you, Ruth. It was a very excellent presentation. I enjoyed that very much. We have had several questions come in through the chat, so I'll go ahead and moderate those for you.
Yeah.
Our first one was, could you comment on the methodology/model that was used to compensate for education? Did you rely on external data?
Sorry, I was clicking away my screen. Sorry.
Could you comment on the methodology/model that was used to compensate for education?
So education of the participants, the cohort.
I believe so. That's what they're referring to.
Yeah. So we measured education in years of education, and we covaried for that in our models. So yeah, that's how we took it into account. But mind you that, as I mentioned, the cohort is relatively highly educated. So they're, even though we correct for it, it's still a highly educated cohort. So I think that's definitely very important to take into account in future studies, and also in future enroll population, which are more diverse in terms of educational background, to see whether it's feasible to deploy these digital assessments to obtain reliable cognitive data.
Excellent. Our next question is, the use of slope as a practice effect is interesting, but couldn't a person who has high initial performance, which they maintain over time on the C3, have a low slope? How would we contrast that versus someone who starts low and remains low? These two individuals would have a similar slope, but different behavior, but would be predicted to have similar amyloid levels. Is that correct?
Yeah, really, really good point, that the slope doesn't really take into account where someone starts here. So we in this sample, we looked at the baseline distributions of the individual tests, and we didn't see ceiling effects there. So we sort of assumed that there would be like improvement for everyone. Everyone was able to improve or show that they benefited from practice. But I agree there are limitations to this approach, and with the daily learning that I showed you today, we have we're trying to come up with a more sophisticated method to quantify learning, such as an area under the curve, where you can also sort of that you can scale and sort of correct for like where a person started, because I do agree that is someone who starts low and remains low is probably has a different learning or memory ability than someone who starts high but is not able to improve, or starts low and does improve. So yeah, I think really good points, and we need to come up with better ways to capture the practice effects without ignoring the baseline performance. Yeah.
Yeah, one thing I wanted to comment on this question also to you is that in the linear mixed model that you showed, did you also, as the random effect, did you use subject slope and intercept as the random effect?
Yes. Yeah. Okay. Yeah, we did. Yeah.
So if that were the case, then you at least have that, you have the individual starting point sort of accounted for in your analysis.
Yeah, no, that is true. And also we, I think it also becomes more problematic if you want to include more data points. So like that sort of non-linear trajectory of like a typical learning curve. So when we looked at the first 3 months, it was relatively linear. But like when we look at over the 12 months or the 7 days, if we really want to quantify that learning curve and acknowledge that non-linearity that we expect, because at some point we expect someone to reach their asymptote, I think that's also where an area under the curve metric might be more appropriate. Yeah.
But next question. Oh, sorry, go ahead.
No, I said great question. Yeah.
Have you considered using blood-based biomarkers to assess their relationship with computerized cognitive testing?
Yes, we recently have got access to blood-based biomarkers in the HAPS cohort, or the PIs have, and hopefully we as researchers will have soon. And then we will be able to look at this. And I think especially with the smartphone testing, like the testing on individuals' own device, see how that maybe combined with blood biomarker provides a very scalable approach to identify individuals at risk for cognitive decline is super relevant, because I can imagine when we want to do more large population-based studies or monitor cognition on the population level, we really need these remote biomarkers as well. So yeah. The biomarkers that what we are looking at are or that we are planning to start with are the typical Alzheimer's disease biomarkers, so amyloid and tau. But I also think, it's not my field of expertise, but I think there might be super interesting other markers such as NFL or GFAP to also relate to this learning paradigm.
Next one is, do you think reduced practice effects are reflecting a memory deficit or maybe an executive function deficit?
Yeah, really, really excellent question. So when we compared or the practice effect slopes that we extracted to individual tests included in the PAC-5 and also other neuropsychological tests available, we did see the strongest association with memory and especially list learning measures. So I think that sort of supports the hypothesis that it is a learning memory deficit, especially when you're repeating the same content. So when you present the exact same test every month, I think it is definitely benefiting from having seen the face and the name before and sort of being able to remember that. I do think that when you look at more alternate versions and practice effects that are seen on alternate versions, which maybe more reflect some sort of procedural learning or like test familiarity, I think there maybe like there I would expect to see more associations with executive function as a way of more being able to find a strategy to do the test and become better at the test. So, but I think that what we have been focusing on the learning paradigm is like really re-exposing individuals to the same material over months. I think that is more of a learning, perhaps also including an executive function component, but I would expect it to be more heavily associated with learning.
And do you also see practice effects on standard tests like the AVLT?
Yeah, I think we see like there's a lot of meta-analysis and reviews out there looking at practice effects on annual cognitive testing. And they typically what they show is that we see practice effects on all sort of tests and most strongly on memory measures, including the RAVOLT. And that is actually what we're capitalizing on, because now that we like using remote testing can look at practice effects more over more shorter intervals, like monthly or daily. That's exactly what is based on what we have been seeing on like years of cognitive data in especially unimpaired older adults. Yeah.
Excellent. And have you seen success with gamification to optimize remote engagement in AD to capture daily cognitive performance during gameplay?
Yeah, super interesting question. I myself haven't done a lot of research into that, but I know that there are groups focusing on that, and it's particularly interesting to make testing more engaging to people. And I think so in our cohort, which is a very motivated cohort, they don't mind taking a reaction time test every month, as boring as it may be. But I can imagine that that's maybe not generalizable to everyone. And I think maybe gamification could make the testing more appealing, and which will also allow you to do it more frequently and thus look at things like practice effects and IIV. So definitely an interesting avenue, I think, to explore.
We have one more question. It seems that reaction speed tests should be influenced by unrelated factors of decline, such as vision. And they give the example of whether someone's reading glasses or prescription is up to date. Is there an unsupervised way to extract such an interference?
Yeah, really great question. I think what is really tricky about reaction time tasks is that it really also can differ on the device. So it's like some smartphones or tablets are more like have faster processing time than others. So yeah, I think there is definitely a couple of challenges with unsupervised testing. I think, however, if you focus on intra-individual variability, so you look more at within-person change versus between subject change, I think these issues shouldn't be less of an issue, especially if the person uses the same device every time and the same reading glasses and the same. But yeah, you should sort of find a way to control for that, maybe by letting people attest that they are doing it in the same, using the same procedure, or find a way to check that. But I think that is that is a challenge, I think, with remote reaction time. That is less of a challenge when looking at accuracy score, so with the capturing practice effects.
I have a question that I think maybe everyone may be interested in is, in terms of the iPad testing referred to, I think it was the C3 battery.
Yeah.
How accessible is that, and how would one go about possibly implementing that into their own cohort if they wanted to do so?
Yeah, so the C3 that we showed you is based on Cogstate software. So that is well, it is available, but it has I think it comes with with a certain price. You have to I don't know what the amount is, but I think research would have to pay for it, which maybe makes it a little less accessible. The daily learning that they're doing is the branch data, and that is available for researchers upon request, and we actually have a website. So if you're interested in leveraging the daily learning paradigm, that is very accessible. I think it's also I mean, we've shown this with these particular tests, but I think it's more the paradigm. Like if you have a phase name memory test in your own platform or in your own group available, like repeating that over a month could give you sort of a similar paradigm. So it's not maybe necessarily the actual tests, but more of the paradigm that I think is really interesting. But yeah, if you do have any questions or are interested in the daily learning, please feel free to reach out, and I can connect you with our group.
We have one more question from an attendee. Were factors such as sleep quality and caffeine intake considered?
Yeah, great question, because I think what the person is getting at is that might be influencing your reaction time. So and this affects the intra-individual variability. We did not have any information about like whether people at that specific month had more caffeine than the month before, or slept well, worse, or not. The only thing is that we asked them to take them at the test at the same time of the day each time they took it. But I also think it's more like showing that some people, like regardless of whether they had more caffeine or not at one point, or whether they had a better night of sleep one month than the other, some people are like, despite that, they are super stable over time. And I think it's actually so being resilient to these daily fluctuations and still showing a consistent trajectory in your reaction time is sort of what shows that sort of showing the value of looking at IIV. So it's not necessarily what's influencing it, but the fact that you're resilient to these day-to-day variations is saying something about your brain health and cognition.
We have one last question that just came in. Have you considered trying these at the AMC, different culture and group? Not sure I know what that means exactly.
Maybe the Amsterdam. Is that Amsterdam? What you're referring to?
Yes.
Group? Yeah. No, not yet. But definitely a future step that I would like to take. So we would have to translate some of these measures into Dutch, or use existing validated Dutch measures to do this, and that would be really interesting to do. Yeah, great suggestion.
Right. Well, Roos, thank you very much for your time and for sharing your work today. I do appreciate it very much. As I did mention, the recording of this webinar will be available very soon today. I will send out a link to everyone who registered. So thank you all for attending, and thank you again to Dr. Uten for being available today to talk. I really appreciate it. And
yeah, thank you for having me. I really enjoyed it. Thanks so much, and for the great questions.
Thank you, and have a great rest of the weekend, everybody.
Yeah, thank you. You too. Bye-bye.